Hi, I'm Dr. Hesch, physical therapist at Hesch Institute in Aurora, Colorado. And this brief presentation is on a pattern that seems to be diagnosed regarding sacroiliac joint dysfunction in a certain part of the country. And that is a right upslip with a posterior rotation of the ilium. Now, this diagnosis is typically based on palpatory landmarks encountered in standing and palpating the pelvis in standing with gross movement of the trunk and spine, and looking at landmarks while the person bends forward, and also looking at landmarks and landmark changes when the person lifts their hip. These are very, very general tests, and most of the movement with these tests happens in the hip joint, and cannot truly be ascribed to the sacroiliac joint. They're overrated. Research has shown that these tests actually do not indicate movement in the sacroiliac beyond 2 millimeters of glide or 2 degrees of rotation. And that's a very, very small amount of mobility to be perceived manually. So these tests are certainly questionable, and I have found that when people lay down, the presentation changes from what was seen in standing. I've learned not to trust what's in standing because our standing posture captures all our compensations for what is the true problem. And the true problem is best encountered when the person is laying down and you do passive spring recoil tests to determine which side is stuck, which direction is motion stuck, or which direction is motion excessive. So I have to say that when someone looks like they have a right anterior ilium with upslip in standing, when you get that person to lay down, typically they present with an anterior ilium. Interestingly, some of the self-treatment or the adjustments or self-correction for a right posterior ilium with upslip is paradoxical, because it's not really the correct adjustment for that pattern. So I thought I would show what a correct adjustment would be. And first I'll talk about the correct adjustment for an upslip, which can simply be quadratus lumborum, increased muscle tone in the quadratus lumborum and the external obliques of the abdomen. But a self-treatment for that would be to lie on your bed sideways with the right side on top, and the top leg would come backwards. You draw a line through the shoulder and through the hip in front of the knee. So you take the knee backwards so that there is an anterior rotational force in the pelvis, and that stretches the quadratus lumborum and the external obliques, but it also rotates ilium anteriorly. And so this can be a very, very effective self-treatment for a right posterior ilium with upslip. Another effective treatment for and I did mean to say right posterior ilium with upslip. I hope I didn't say the wrong thing, so let me clarify that. A self-treatment for a right posterior ilium can be done with a rolled up towel about 2 inches thick by 8 inches firm, or piece of foam that's 2 by 4 by 8 inches. And what I would do if someone presented with a true posterior ilium on the right is I would place this foam under the belt line, so it's under the superior ilium, and if using the table here, I would have them scoot over to the right side. And then they move the left leg out of the way, and they move the right leg across the midline at about 30 degrees of abduction. Okay, make sure it's comfortable. You can certainly bend the left knee for a little more comfort. You don't have to take it to end range. Make sure you're comfortable, and you could do this for 2 minutes, and that would encourage an anterior rotational force for the pelvis. There's one other technique, and it involves lying on your back. So you could lie on the side of your bed, and you comfortably bring both feet over to the left side, and the pelvis comes over to the left slightly. The only effort I put into this stretch is to keep the right leg in towards the midline, and I let that hang. And if it is suspended, then it is being done correctly, and over the course of 2 minutes it will slowly give little releases, and it'll stretch and induce a force that rotates the pelvis anteriorly primarily anteriorly on the right side. And so if someone has a true upslip on the right with a posterior ilium, which I must emphasize seems to be overdiagnosed and is extremely rare from my experience of looking at them in standing, but also evaluating them in prone and supine, and using up to 16 passive joint stress tests called spring recoil tests, also called passive accessory motion tests. I can say that that is extremely rare, but the correct treatment for that pattern has been demonstrated. I hope this is informative. Thank you very much.